I guess that I can be your first patient. I believe the challenge that you have with this proposal is not only storing the data. How do you have access to that data? I mean, we're talking about there are many hospitals in Cuba in every province. So how do you foresee this is going to happen in a way? How do you obtain the data? Probably didn't get it done. The explanation problem.
Well, as we mentioned, the data that we need in order to make this functional is actually pretty minimal. So pretty basic supply counts and patient check-in information is what's needed, and that can be kept on pen and paper records, which can then be mailed to regional districts and then compiled all together in a central location by even just a couple of people working as data input specialists that just read from a paper form and put it into our program. Alternatively, for the hospitals that can be more modernized, we did take into account the cost of providing computers and tablets to the doctors that are either in local clinics or in major hospitals.
Okay.
Just a couple questions. One, your database, is it expandable? Is it scalable? Because I see with the tablets and so forth, the capture of things besides numeric data is possible. Have you guys thought about that?
Yes, it is expandable in a way. The one that I showed you here is a very simplified model of it. So in the final version of it, you could have way more information for each patient and doctor. And yes, we thought about the implementation with tablets and thinking of algorithms that can use this information in the database along with simple apps that you can use on a tablet to pinpoint diseases and stuff like that and symptoms and help doctors diagnose their patients by looking through the database automatically to search for similar symptoms and whatnot.
Are there dependencies? Can you have dependencies between the data? One patient to another patient?
Absolutely.
So you theoretically could have a photo of the patient. You could have the family history, which would then open up the realm to do preventive care, right? You could...
Absolutely. That's absolutely the idea that we had in mind for the future implications of this kind of technology.
Okay, last question. On the cost, do you have any idea of the economic impact that would be, or have you at all thought about that?
So regarding the economic impact, we never really dived onto that idea. We do know that our financials are a bit out there with the numbers, but we are trying to implement a supercomputer. So that is ideally why the $35 million is needed, but the actual economic impact has never been calculated, so we never took that really into consideration.
Good job.
Thank you. Thank you.
Very quick, because I've seen many of these presentations, and I've got to tell you, gentlemen, it was an outstanding delivery. I will make this comment. Your presentation here today was much more focused and precise on what you wanted to convey than what was written. It took me a little while in the writing to understand exactly what you were trying to accomplish as a non-computer science person. But I got to tell you that today you made a very complex issue, you took a very complex issue and delivered a very practical solution. So I congratulate you for that.
I also think that you have tackled a very complex project. And I'm wondering, how do we go from here to there? And in that sense, have you gathered any experience of how this has gone in the United States, how bioinformatics have been introduced, and the ease or difficulty of introducing that in future Cuba?
So not necessarily in the United States, but there has been other countries in Europe who've implemented a centralized-based healthcare system and have had tremendous impact on the healthcare system. That system works ideally so a lot of basic trends can be set and a better healthcare system, a better healthcare profile for the individual can be made. So that is what our true idea was. I don't know if anyone wants to add in. I mean, also, if you look at a company like IBM, they've been working on the Watson computer, which is artificial intelligence, and a lot of the things that they've been trying to do is sort of like to map the human genome, which is a little bit more extensive than we were covering the scope of our project. But this allows for like the tracking of not only just physical ailments, but also cognitive, and more than just like you see in like an everyday visit with a doctor.
Yeah, it seems to me on medical information system, you have sort of the patient data, what kind of sickness this person, which is sort of focused on the individual, but then there's the epidemiology type information, which requires speed. And I know USAID for many years has been involved in Peru using cell phones to input the data. So even 15 years ago, but now with Ebola and so on, a lot of people are introducing, because if you can input the data with a cell phone, that means you multiply the input points. And then also processing is very quick, because suppose that you're in a place and they're reporting every week on an epidemic in a place. It goes to the central place, somebody enters it or doesn't enter it. But it seems to me that there are cases you want to have information in real time. And I think your paper would have been a little bit more interesting if you had looked into the use of cell phones to input data.
Well, if I can, in our paper, the cost that we have, the $35 million, that includes the purchase of tablets for each different hospital. So no, yeah, we didn't look at the idea of cell phones by the patients themselves, but
this is by the health workers.
right, exactly. So we have in our estimates equipped each doctor with a tablet. The only reason that we keep it on the potential that it could be pen and paper is because not every location in Cuba is connected to an internet or an intranet that can immediately send data to the centralized location. So it would be much harder in those areas to communicate that data across, which is why we let that possibility open that it could be an old-fashioned weekly report such as that.
Okay.
Yes.
I don't know if you got an opportunity to look into what software you're using in Cuba this time, but you're on the right track. Java is an open architecture, and that's what they're using.
Yes.
So it's very good that you're already starting with this premise that you're going to base it on Java, because that way, position, if you put your group with the other one, with the people in Cuba, that would make that process a lot easier. Now, from what I understand that you're doing, this is the base. This has to grow enormously. Because you see the models here in the United States of how the patient's records are kept and developed. And that record follows that patient everywhere. So that in itself is a huge module. You also have to integrate the communication between the equipment, imaging equipment, and this software. Because that follows the patient wherever he goes. So that should be another goal in the project, to integrate the capability of getting the information from the machines, the images from the machines, and then add it to the patient's record so that it can follow that patient. I congratulate you.
Thank you. And as far as the language choice of Java itself, we did do a lot of research into which kind of data structures would be best for this kind of program. And we did choose Java because of how seamless we thought that the implementation would be from their existing system. And as far as the expansion, yes, the program that we have here is really just the tip of the iceberg, and it's a prototype of just a little glimpse of what this kind of thing can do. And we had big picture implications in mind when we designed it of that kind of expansion.
Thank you.